So thank you so much, Patricia and Karen, for arranging this, and thanks to all the physicians. I know you've at some point received phone calls from me regarding some documentation issues, and I think the whole purpose of this is to share with you our experiences on what the insurance companies say when they deny cases, and then pretty much look at what we do in terms of when we look at each case from your hospital and some other hospitals. And my request is you don't have to make notes, you don't have to write stuff. Everything is being recorded, and you will have access to what you see on the screen, the learning management system. You can actually review these videos, review these slides on demand on your iPads through your system. So all of you should be receiving logins very shortly. And the idea is to share the learning management system with you and then going on to clinical reviews. So what you see on the screen is some topics that are on, and I'll show you the extent of the topics. The webinars that you are getting through live format right now are going to be put on the learning management system. In addition, there are going to be a whole bunch of other stuff for regulatory and clinical compliance, diseases, regulations, stuff that some may be boring, but unfortunately is just now part of the new rules, and we just need to know them. At any point, if you want to put a question in, ask me what's going on, stop me, give a comment, share your own experiences, please feel free to do that. But the learning management system has been designed where each course has modules. There's pneumonia, there's acute kidney injury. What we're going to do today is acute kidney injury, and it opens up in a very fluidic player where you can watch it on your iPad and enjoy the video. At the same time, it will allow you to compare your performance with other people who are on it. You'll get certification badges, which you can share on your LinkedIn, on your Twitter, Facebook, whatever your choice is, to show that you've completed all these topics. And you see this vast range of topics that we have. A lot of what we'll be doing and what you'll find more interesting is the clinical and regulatory reviews. And these are disease-specific, evidence-based guideline issues that are very important in documentation. And most of these cases have either been taken from your hospital or from sister hospitals. So these are going to be real cases where they've either been denied or they've been sent to us for a concurrent review. And then we'll go through what we look at. We'll go through what happens in a peer-to-peer, what the defending MD from one of the insurance companies wants to look at. And that's what our message is, that you need to know the rules of what they look at before denying. The whole idea is this is going to affect payment structures for the hospital. There's a payment financial responsibility for the patient. And eventually, when value-based and bundling comes, physicians on an individual level will be responsible for the lack of documentation. And that's why we want to be ahead of the curve, so that you at least know what the new rules of the game will be. Now, when you look at all the other topics, some of these you may be very familiar with: the 2 midnight rule, the condition code 44. Some things you need to know, some things you must know. And then definitely ICD-10 has not made things easier. And as we proceed, we'll show you why all this is bundled into this one presentation. And so you get a bigger picture of whatever you write on the note, how does it actually affect payment for the hospital. So there's a disclaimer that you will see on all slides on the learning management system. And it pretty much means that, you won't record this and sell it on eBay. I don't think anyone on eBay is going to be interested in it anyway. So let's start. What are we being bombarded with right now? So as recent as October of last year, there was ICD-10. A year before, there was the CMS 1599, which is the 2 midnight rule. Prior to that, we had the EM audits, and then there was the ACO program. Now there are QIO, CERTs, RACs, MACs, ZPICs, the OIG, the Department of Justice. In addition, there's HIPAA, HITECH, OCR, and the CMS, payers, and all the insurance companies. So these are all what are against us right now. And this is a lot to take. A lot of them, there's going to be documentation issues, what they think there is fraud and abuse. We have very few supporters in the system who really think that healthcare, hospitals, providers are doing a good job. We may do everything right. Patient may actually walk out happy saying we did the good thing, we made them better. But again, these guys are watching us to say, hey, did we charge $1 more than what we should have? And if there's, let's extrapolate it to the last 1,000 cases over the last 5 years. Whether that's right or wrong is a matter of debate. I think the purpose of this is we need to know what the rules of the game are. So you can see this slide. These are the people who look at the hospital, who look at the healthcare environment, and then who actually audit the physicians and the hospitals. And by color, if you look at the bottom two, and I'm going to change this slide, if you look at these bottom two, they're in green. They're routine compliance issues, so the QIOs and the certs. When you go on to yellow, these are the compliance oversights. These are the RACs, MACs, and the mix that are looking at the hospital. But move up to the red department, if the yellow and green refer you to the red, that's where there's a lot of legal oversight. That's where these could be civil charges, not only against the system, but against the provider. And that has been happening very recently as to some providers in Nevada. So the Department of Justice, the OIG, the ZPICs, we need to make sure we are in compliance with what they want us to do. And not to leave alone the insurance companies who are now sending notice of improper payments and recoupment for disease-specific issues. And that's where we come in. As physicians, we've learned what acute kidney injury is, but now we just need to relearn on what they are looking at when we write a patient comes in with a creatinine of 5. Unfortunately, that's not enough for them. They want a whole bunch of other stuff that they want to put in. So let's start with two cases, and our topic for today was acute kidney injury. So we'll discuss these cases as we go on, but this is just for to keep at the back of your mind. So these are two cases from your sister hospital, from the Cookville system. 71-year-old asymptomatic female presenting from her PCP's office to the ER with abnormal creatinine levels of 2.6 noted during routine preoperative workup for right foot surgery, and she got admitted. The second case that happened a day later, 55-year-old male presenting to the ER with 2-day history of intractable nausea and vomiting with progressive weakness, creatinine level of 3.1, and a recent diagnosis of myeloma. And as we go through the presentations, I want you to keep these two cases in mind and just think of what you think bedding status should be. One question you should think is, should either of these be in the hospital? And two, if they should they be under observation or inpatient? And then day 2, if they're in the hospital, should we change or should we not change? So let's start with some clinical issues. What we'll discuss, and this will be the format for pretty much all our disease-specific reviews, we'll start off with some definitions, some pathophysiology, signs, symptoms, use of secondary diagnosis, ICD-9 and 10 changes, screening tools, and coding tips. And the idea is not to teach about kidney failure. The idea is just to tell them these are some specific semantics that should be in a progress note, and then you'll see some dollar amounts that are affected on what you write and where you write. So over these past few years, there have been a number of kidney foundations or organizations, and each of them have come up with their own sort of definition, their own sort of collection for research. So the National Kidney Foundation is one. The KD, the clinical practice guidelines, what you hear right now are the KDIGO, the KDIGO. And this is another organization. They developed these guidelines from Asian and European countries. So huge international effort in defining what these guidelines are. Then there's the kidney failure risk equation, again, based on urine, sex, age, the GFR. This was a 30 plus country effort. Let's see, we have what is now the CKD epi equation to calculate the GFR. So over the last 20 years, there have been about 6 ways to calculate a creatinine clearance or a GFR. And what we learned many years back, the Cockcroft-Gault equation is no longer valid. What came out as the MDRD equation is now not being used. What is now being used is the CKD epi equation. And why this is important, we're going to tell you that the equation is actually dependent on race. So blacks and whites and Caucasians, the creatinine will be different. It differs on age and it differs on sex. So if you have a creatinine level of 0.7, the GFR may be a completely different function. And why the GFR is important comes down into our documentation on who has acute kidney injury or not. So just depending on what lab, on how your lab calculates the GFR can actually affect whether your patient has acute kidney injury or not. So leave alone what you think, an MDRD creatinine of 0.7 with a GFR of 80, as soon as you change the equation, change the demographics, change the race, that same 0.7 creatinine could be a GFR of 50. And that's the arguments we usually use when we're doing appeals, that we look at the creatinine and we look at GFR. So let's start with this 141-page review of the KDGIO guidelines. And I'm just joking with you. I'm not going to go over these 141 pages. I'm just telling you the fact that more than 50 countries have come up with these guidelines. These are exactly what your insurance payers are using to deny your cases. And I know Sheila and Karen, we talk about denials that come from different insurance companies, and they refer to the rifle criteria, they refer to the Aiken guidelines, but currently they are referring to KDIGO guidelines. And it's very important for the physician groups, the healthcare providers, to know that this exists. The reference to this will be in the evidence-based and in the learning management system. Once you click on it, it will take you to this PDF file, and you can see what sort of things they look at. And this forms the basis of our discussions. This forms the basis of our recommendations on what needs to be in an HPI or a progress note or an assessment and plan for the cases that we review for you. So this was these guidelines were made in 2011. Again, they were optimized in 2012. They talk about assisting the practitioners for caring for adults and children at risk for acute kidney injury. Now, there's a bunch of chapters on definition, risk assessment, evaluation, prevention, treatment. They talk about rifle, they talk about the Akin, they talk about different studies and what the relationships are. Why it is important for us is to know that all this does exist. And it's important for you in case you get a call from an insurance company denial stating some criteria. Well, you need to know that your physician's documentation was at par with what is out there in the evidence-based literature. So let's talk about acute kidney insufficiency. And that is the commonest reason a patient with a renal issue comes into the hospital. Now, this is this early stage of renal impairment before it evolves into renal failure. And if you notice the top line, acute kidney insufficiency, the next line will be acute kidney injury. But insufficiency is where someone comes in due to dehydration, that's pre-renal, or an obstructive process. There is a rise of creatinine from 1 to 1.2. The patient's dehydrated. You give them IV fluids, a few boluses, and for a few hours, and patient returns to normal. Creatinine is normal. So that is not acute kidney injury. That's acute kidney insufficiency. And most of our audit discussions are based on this specific fact. Was it an insufficiency or was it an injury? Well, comes down to the question from your end is, well, what is an injury then? So there is a definition for acute kidney injury, and that is the increase in serum creatinine by greater than 0.3 within a 48-hour period. or an increase of serum creatinine to 1.5 times baseline, which is very important in our history, is we dig out an old record to tell us what the baseline is. Someone coming in with a creatinine of 2.5, if this patient has had chronic kidney injury for about 10 years, that is not going to be an AKI because we know the baseline is 2.5. The other thing is urine volume. So they have placed a lot of importance on oliguria or anuria. Someone comes in with a creatinine that's elevated and has not peed for over 24 hours and now has a creatinine of 1.8, 1.10. We need to make sure we've put in the presence of oliguria or anuria. And that is one of the criteria for the AKI. Now, the rifle criteria has been around for a long time. And if you look at this, it's based on the categories of risk, injury, failure, loss, and end-stage kidney disease. And it is similar. They do talk about GFRs, the increase, whether it's 1.5 or 3 times. They talk about urine output, again, coming back to the anuria, oliguria discussion. And they talk about the specificity and sensitivity of the rifle criteria. This has been taken out from the KDIGO guidelines. And what I want you to emphasize is this red box, because they have commented on kidney damage being assessed by pathology, urine or blood markers, and imaging. And in cases of CKD, kidney transplant, which gives us the cue that these things should be addressed in our progress note. So if you've had someone coming with glomerulonephritis and you have a pathology or a biopsy result from a few weeks back, mention that in your HPI. Urine and blood markers, again, a lot of the nephrologists will order 24-hour urine collections. Sorry, someone had a question? Okay, so urine and blood markers need to be part of our HPI, our progress notes, and then imaging. A lot of us order renal ultrasound, some don't. But in cases where you don't have one, you will not be faulted for overutilization if you do end up ordering an imaging. And why it's important is this is one of the structural criteria for kidney damage. So if you look at acute kidney injury, we know the functional criteria. We've talked about creatinine and the presence or absence of oliguria. There is no documentation that there has been kidney damage on the ultrasound or imaging. But if you look at chronic and acute kidney disease, there is a GFR, there is a functional criteria, and then they talk about kidney damage for or less than 3 months, which on an ultrasound may show small size of the kidneys or cysts on the kidney. But that's very important to document that. Now, in terms of severity, but also in terms of your management. So if someone comes in for acute kidney failure, giving them fluids, then your discussion needs to focus, hey, we took care of, we checked the creatinine, repeated creatinine levels, the PTH levels, and then we ordered a renal ultrasound, a CT scan of the abdomen, whatever you think is appropriate. But again, imaging has now become one of our reasons for peer-to-peers when we talk about, well, this patient was sick enough to have functional criteria with an increase in creatinine and structural or anatomic criteria showing that there is damage or there wasn't damage. Any questions so far? Okay. Let's move on to our next slide. And again, this is something that you can look at during your viewing of the learning management system. You will have all these slides. You can review the video presentation again. But again, it just talks a little about acute kidney disease, chronic kidney disease, what is our pathway we need to look at. A lot of times, if this is being used for your progress note documentation, it definitely helps the payers to say, these guys knew what they were doing. They've done a good intensity of service. The patient was sick. There's no need to audit this case or deny this case. So why did we have to come up with acute kidney injury insufficiency criteria? Well, the discussion was it's a very common diagnosis. There's high morbidity, there's high mortality. But the question is, there was a really high cost per case. And that's where these guidelines came in. They felt that if we had criteria, we could detect them early, prevent them. There would be a decrease in variation in the practice guidelines, which is varied indefinitely at right now. And then they wanted to improve outcomes and reduce cost. And all these discussions, I know the physicians in there are wondering, why are we talking about this? You know, a lot has happened in terms of the disease processes that CMS and the payers have been paying, and they've just felt that the cost of care has gone tremendously high. And what they want to do is decrease variations and say, well, follow these guidelines. I'm not a big fan of guidelines. You know, I look at cases on an individual basis, but we need some baseline criteria on which we all have to document. Anything that I've said right now is nothing new for the group. I mean, this is medical school stuff that we learned. It's just now that it's been packaged into a way that we need to know the rules on how they want us to document. It does mean an added burden on documentation to the physicians, and that is completely valid. There's a huge administrative burden to the support staff, and then there's a financial loss to the hospital. So all three of us need to figure out, you know, if we do this the right way, we won't be at the losing end. And that's you know, the whole purpose of why we started all this. So yeah, please go ahead. So what has happened is, and this is directly from CMS. Each note needs to stand on its own in terms of payment. So if your HPF, your chief complaint for day 2 for this patient is patient improving, your discussion needs to show what this patient is in for the hospital today. I mean, you did the echo yesterday, the ultrasound yesterday, you looked at the GFR yesterday, but if you comment on it today saying, well, there's an improvement or there's worsening, that actually makes that day 2 of hospitalization can stand on its own ground when we're asking for continuation of stay payments. So unfortunately, yes. Now, what you are saying is unique to your hospital because you have to type in or write all that stuff on a daily basis. What is now becoming a bigger problem for other EMRs is the copy paste. So they don't have to do anything. All they do is copy from page 1 and then put in 5 lines that becomes the page 2 progress note. And it's a 7-page progress note with everything since the patient was born. It's that. I think it's a redundant and useless way of doing it. But the sad part is day 2 of that progress note is going to stand the test of payment time tests. Does that answer or does that help? Okay, all right. So let's come back to our 2 cases. So 71-year-old asymptomatic female, PCP's office, creatinine of 2.6 during routine pre-op workup for right foot surgery. So any comments? Does this patient even need to be hospitalized? All right, so the baseline is 2.5. Okay, good. I'm glad you guys said this answer. So just for recording purposes, the group said no. Let's talk about the second case. So let me go on to the first. So unfortunately, this patient was hospitalized, stayed in the hospital for 4 days, got denied, and during our peer-to-peer, this is exactly what we discussed on what your answer was. She doesn't even need to be in the hospital, so inpatient, observation, outpatient doesn't make any difference. But in reality, she was in one of the facilities for 4 days. So that's a loss for that hospital. Let's talk about case 2, 55-year-old, 2-day intractable nausea, vomiting, worsening weakness, creatinine 3.1, diagnosis of myeloma. What does the group think? Hospitalization, yes or no? 0.8. Okay. So for recording purposes, the baseline was zero point 0.8. The group says yes. And the let's move on further onto this. Inpatient or observation for patient number 2. What does the group think?
Probably inpatient, but what was the BUN and is it more pre-renal?
Okay. So excellent points, because this one, and we'll go through this because I have screenshots of the labs in this case also. But you're absolutely right. We did the presumption that this patient would stay in the hospital for greater than 2 midnights was there because of the need for the IV fluids, the massive percentage increase from baseline creatinine, and the fact that he was symptomatic. And we'll show you in the next few slides. But I'm glad we all got these two cases right. So what we all do great is the history and physical. Where we falter is the continued stay. And that comes back to one of the questions that was asked a few minutes ago is, on each progress note on the subsequent day, do we have to write the creatinine and the imaging? Well, we need to justify what the severity of illness is. So what is the condition that can only be treated in the hospital? And then the intensity of service. What are we doing that we can only do in the hospital? So agreed, the condition is acute kidney injury. The creatinine level has bumped up tremendously. But if there is orders for no fluids or fluids of KVO or keep vein open or fluids of just 10 cc's an hour, so the patient is sick, but we aren't treating that. And that's where the discussions happen. Go ahead.
I have a question right here that I always wonder about because the case managers say that it needs to be 125 cc's an hour, but if you document that they have CHF or other comorbidities, can you do it at 80 cc's an hour or something? Is that reasonable?
Absolutely. So where they're getting the 125 cc's an hour is the screening criteria, and all of you know about Milliman and Interqual. The fact is, during all our peer-to-peers, during ALJ hearings, during RAC hearings, there is never a mention of Interqual or Milliman. There is always a mention of medical necessity. So if you write patient is an acute kidney failure with creatinine of 2.5, there is a pre-renal component, patient has pre-existing heart failure with injection fraction of 45 or 30%, and I am worried about a cardiorenal syndrome based on fluid overload, you can put the patient on 30 cc's an hour if you want. The thing is, you have acute kidney injury, you've given the treatment of fluids, and you have an extreme concern for heart failure. And in a few slides, you will see why that worry and concern is actually a financial benefit to the hospital and eventually to you. So hold on to that thought about the fluid rate. But you're absolutely right. Please choose the fluid rate that you think is appropriate for the patient. And there's a calculation of finding out fluid deficit. 125 is an arbitrary number used by the screening criteria. But as peer-to-peers, we don't even talk about them. And when someone does refer to them, it's very easily dismissed. So it's nice to know that there is a fluid rate to give us guidance, but that should not be determining your treatment protocol. Does that help? Okay, so when we talk about kidney cases, we're talking about acute renal failure, acute kidney injury, there's kidney stones, there's chronic kidney disease, there's cystostomy complications. If we have imaging, there's a hydronephrosis, hydroureter issues, nephritic syndromes, polycystic kidney disease, pyelonephritis, UTI. So what I'm only touching, I'm just scraping the tip of the iceberg with this. There's a whole bunch of things that we already know. It's just that we need to rewrite them in a semantics that CMS and the payers understand. Now, there's other issues of missed secondary diagnosis. So if someone with renal failure has low potassium, high urine chloride levels, we need to be sure we document the presence or absence of renal tubular acidosis. Now, I just took my medicine boards and I've learned RTA 6 times before the exams. And the day after the exam is something that's not even in the back of our heads. So the idea is they want you to know this. Now, if someone comes in with renal failure, intractable nausea, vomiting, completely confused, family says this is an acute change of baseline for my father, encephalopathy is something you need to write, and that may actually be a metabolic encephalopathy, but it needs to be written because it increases the severity that your patient will stay in the hospital much longer. The disease severity index goes up. From an hospital standpoint and an auditor standpoint, reimbursement goes up. And from your malpractice standpoint, if there is an event that happens to this patient, it's in the document saying this patient they had malnutrition, hemiparesis, there was encephalopathy, there was cachexia, the patient had a renal tubular acidosis going on. So all these things help formulate the case. And I'm not discounting the documentation, but there's an article I'd written a few years back for the Society of Hospital Medicine about red flags in documentation. And that was picked up as one of the learning points for one of the malpractice companies for their physicians, saying you just need to write appropriately so that we know how sick your patient was. And that translates to them saying, you took care of a sick patient, the charges that you're sending to us are appropriate, we'd be happy to help and pay. Now, comes to our screening tools, and again, I don't mention interqual Milliman, those are all copyrighted, so that's why we talk about what they talk about, and they've taken a lot of information from UpToDate and Harrison's textbook of medicine. So interqual Milliman did not invent their criteria. They've pretty much used what we have learned. They've used information from Cecil's textbook of medicine, Oxford textbook of medicine, and Harrison's textbook of medicine. So combined, that's 5,000 pages of medicine that they have made their computer program. But that's something we learned in med school. So definition is what they talk about. As you mentioned, IV fluids and rate. They talk about risk factors. They talk about the presence or absence of cardiorenal syndrome and CHF, electrolyte abnormalities, and secondary causes. And why this is important is these are the exact 6 points that your progress note should focus on in a patient with AKI. And as you go through the series of learning management system, all the 15 DRGs, the bread and butter of medicine, you'll see what you need to put in your progress note so that it's satisfied not only as a good medical record, but it satisfies the screening tool also. And eventually, the justification of payment. These are the same things that your insurance companies use to look at whether the documentation was complete or not. So let's talk about this simple case. Presents with renal failure, has a diagnosis of CHF, and the DRG is 684. So all said and done, the hospital at the end of these 3 or 3.5 day stay should be getting about $7,400 or $7,500. But this patient, there's a CHF component to it, and you write in your diagnosis, well, there's renal failure, but this patient has a systolic heart failure. The ejection fraction was 30%. We did an echo from 3 months ago, and I looked at it, and there's valvular issues, but the same patient with a different semantics of documentation, now you can see the difference of 8,600. It hasn't changed on what you're doing for the patient. It hasn't changed the treatment that's been given. It has just changed the severity of illness and the disease index. So your hospital will now should get paid 8,600. Now, coming to your same question, you gave them a liter of fluid bolus, and then put this patient on a 125 cc's of IV fluids to satisfy your case manager saying, well, it doesn't meet interqual. Unfortunately, this patient went into heart failure. You did a chest x-ray, there was florid pulmonary edema, you now had to stop the fluids, give Lasix, but the DRG now changes to 682. Or there's renal failure and you found a hemoglobin of 6, you transfused 2 units of packed RBCs, the hemoglobin went up to 9, but the patient 8 hours later was in florid failure. So now you can see you have done absolutely everything right. You've written all this, and now your DRG is 682 with major comorbid conditions, and the reimbursement has changed to 9,500. So just the same patient, renal failure of CHF, 7,468, renal failure with comorbid condition of systolic heart failure, 8,652, and renal failure with a major comorbid condition, 9,526. This is what we look at. This is what the insurance company, say you submit a claim for this patient, they are now going to put a major emphasis on the acute on chronic systolic heart failure, seeing why it happened, what you did, how did the patient respond, and their main goal is, let's move down from MSDRG of 682 to 684, and that's when the hospital sends us the case saying we've been asked for a recoupment of $2,500 or $2,000 on this case. How can you help? When we go look at the documentation, if this is what you're billing, but you haven't commented on the heart failure, there's no way we can justify this DRG. Does that help anyone in why the documentation is important on this?
I have a question about that. I understand the why. You said we have to document it. Exactly what do you mean? Are we talking about that you have to say acute heart failure or chronic heart failure due to iatrogenic fluids, or do we just have to list it in the progress note as an impression, or how much documentation do you have?
So let's paint a story. If you are asking me for so the question for the recording is how much documentation is needed to make sure we're in compliance with this, and the short answer is you need to build up the story in the format of your progress notes. So in a subjective saying patient was anemic, was given 2 units of packed RBCs, now complains of dyspnea and shortness of breath, and pulse oximetry is 88% on 2 liters. We had to bump it up to 4 liters to maintain 94%. On your examination, you need to put in, we heard bibasilar crackles up to 1/3 of the basis on patient sitting up. On your neck, you need to mention whether you saw a JVD or not. On your heart, you need to mention whether these were muffled sounds, whether it was irregular or not. On your extremity exam, you mentioned whether you saw 1 or 2 plus pedal edema that wasn't there the day before. On your labs, you need to mention the BNP initially was 600, but now it is 6,000. On an X-ray finding, you need to mention pulmonary edema. On your assessment, you need to mention acute kidney injury, IV fluids. Next point, acute exacerbation of congestive heart failure due to iatrogenic fluids or due to blood transfusion. Plan is to withhold IV fluids, start diuresis, do NEP breathing treatments, respiratory treatments, ambulation, and then in your discharge planning, let's get home oxygen for her. Now that would convince me that yes, this patient did have this renal failure, did have the heart failure. Now, how easy is it to write that? And I'll give the answer will be based on about 8,000 reviews we've done in the last 5 years. On a Monday to Friday, it's very easy for physicians to document it. Come Saturday and Sunday, only 10% of what I just said is documented. Is that consistent with what your impression is on why we get denied more on weekends?
I don't know that I've noticed that about weekend denials. The way I do it is more that you send something to the case manager and they tell me, and then I document it for the next day. But on the weekend, I guess they're not here, so maybe there is.
Yeah.
Yeah, I can understand.
And the weekend issue is not unique to your hospital. We are in 18 hospitals across 5 states. The weekend and national holiday issue is everywhere. So that's the sad part is the auditors also know that. The weekends are the low-hanging fruit for the auditors. They know it's happening, and that's what we try and prevent. A lot of times patients don't get discharged on the weekend. Sometimes, and again, not to your facility, not pointing to anyone, But a lot of times they say, I'm just the weekend rounder. Primary physician or primary hospitalist will be here on Monday. He'll take care of the discharge. Unfortunately, that pretty much ties our hand when we're doing an audit. Whether it's the ALJ or the medical director of an insurance company, they're going to say, so doc, you mean to tell me patient just sat there waiting for the doc to come on Monday? And if there's nothing in the chart, my answer is, I don't have information to comment on that. But I think, we all know that this happens more than it should.
Don't you think they're doing a lot more with secondary diagnosis now, where they're asking for money that especially the higher, maybe the higher payer?
Oh, absolutely, absolutely. And the prime example. So the question for the recording is: do you think there's more of secondary diagnosis recoupment going on? So just these three cases, it's the same patient. You can see 9,500 versus 7,500. I mean, to try and recoup $2,000 back is a very easy task for the auditor, saying, prove that all this was documented in the 3 or 4 days the patient was there. And a lot of times these letters come in 1 or 2 or even 3 years later. Their point is the hospital is more than willing to settle in about 60% of the cases. They'll say, go ahead. I know, we're looking at that. We're trying to help you on that, but a lot of it is, the what was a requirement in 2012 as terms of awareness of all this wasn't there. So I personally think it's unfair of them to go that back, but they are allowed to do that. They are sometimes the look back period could be as long as 7 years, and unfortunately that's part of the hospital contract with the payer. Some of the hospitals have now revamped their contracts to a look-back period of 3 years, which is consistent with the Center for Medicare and Medicaid Services. But if your contract says the look-back is indefinite, the part is, did we even know all this in 2012? And I think that's the part where we try and help. The specificity of documentation has just taken off about 2 years back. Prior to that, writing acute kidney injury IV fluids was enough to get you the full payment. So,
Can they use today's guidelines to deny 5 years ago?
and that's where we come in. They cannot, because a retrospective denial, it cannot be based on current guidelines. What we have to base ourselves on is what did we know in 2012. But again, in the documentation, even in 2012, it wasn't a rock solid documentation at that point. So if they had, saying based on the, at that point we had the Aiken or rifle guidelines with a Q element in it, we don't document that way. We just don't. Even as of today's date, we don't use these new guidelines. We use what we think is appropriate. So it's difficult to justify. Are they allowed to do it? Yes. Should they do it? My answer is no, but I don't think we have control on what they do. My only point is we need to appeal every case, and sometimes the appeal may just be based on the exact point you said, Teresa, is the guidelines weren't clear at that point. Now you have to realize, once they start figuring out, hey, we just won one recoupment from 2012 from hospital A, the next step is, well, let's start looking at respiratory failure. Let's start looking at sepsis. Let's start looking at ileus. Let's start looking at seizures. So once they know that, the hospital is not in a position to appeal, then you'll start seeing a lot more cases come up. And at some point they'll say, well, let's just extrapolate it to 5 years of all acute kidney injuries, and you can pay us $2 million back. Now, what I'm saying has actually happened. So this is not a hypothetical issue. It's already happened with a facility. Now they are appealing it. Again, the cost to appeal, you need to figure out if it's going to cost you a lot to appeal. A lot of hospitals say, it may just be simple to settle for a lesser amount of penalty and then look forward from today, so that from now onwards, we don't get audited in that fashion. And I think that's where this whole concept comes in, is our documentation needs to be rock solid today. Whatever happens 4 or 5 years ago, if we are rock solid, if in this page we've written our electrolytes, we've written our fluids, we've written our rate, we've written our comorbidities, the altered mental status, the age, the nursing home status, even if they do audit us in 2021, well, we did what was right today. And again, this is pretty much beating the same drum, rifle criteria. The reason is it's being used so extensively that it should now become second nature. When someone comes up with a bumped up creatinine, we need to write what their urine output status is. Oliguria or anuria is a very powerful description, but it needs to be put in correctly for us to fight appeals and for them to say, these guys know what they're doing. We don't have to audit them. What they have been coming back once you've done a great documentation is, whether the documentation shows that the medical problems or those circumstances are medically necessary. So not everyone needs to get care in the hospital. A lot of care that the hospital is doing can be done in a nursing home, can be done at home. But what they have been very clear about, and this is from CMS, is if the condition that caused the patient to be in the hospital is present, beneficiary inconvenience in terms of time and money is not considered a medically necessary or continued hospital stay. And there was an open door forum right after one of these havoc snowstorms that happened that caused some people, the government to shut down roads so that patients who were ready for discharge couldn't go because, there was a curfew in place. And one of our colleagues had asked CMS in an open door forum, well, it was a government reason, a federal shutdown for roads due to patient safety. There was a curfew. How could we discharge? And if the patient crossed the midnight, then shouldn't that be covered? And their answer was no. And that was based on a precedence when the hurricane that slammed the New Jersey coast caused some of the hospitals to close down, some patients to be transferred. They actually audited those hospitals that were transferring for recoupment of payment. And some of those hospitals have sued, but the fact is CMS says that it's part of your manual that it was an inconvenience to the hospital or to the beneficiary, and so we're not going to pay for those additional days. Now, what we did at that point, that was right, that was safe for the patient. I feel the hospital shouldn't be punished for that. But again, that's up to the hospital to decide and about the appeal process on those. But there's a lot of discussion about beneficiary inconvenience. I know most of us have these discussions during some of our cases. A patient's 90-year-old, just not ready to go home. What do we do? And my answer is always, I completely agree with you guys. You're doing the right thing. Unfortunately, the payment stops as of 8 p.m. today because the physicians had written patients okay to transfer to nursing home, no further medical issues. Now, some hospitals have started giving patients a notice saying, well, this is when your medical necessity time stops, and we are not going to pay you. We will take care of you, but you're going to be billed for it. And that has not gone well because that's a public relations nightmare for hospitals, for their source, their referral source to say, that this hospital is just charging us more than they should. So it's how do you develop relationships with your nursing homes, great discharge planners. It's not easy because 90-year-old with an unsafe discharge, the last thing you want is to send them home early, have them fall down and come back with a brain bleed. That's just not right. We get it, you get it. I think it's just a matter of time until CMS starts to see that we should be paying hospital for that sort of care until we can get them a safe discharge plan. But again, what I said is actually in the Medicare's publication. So, believe me, I'm not making this up. I'm just telling you that there's a 2,200 page Medicare guideline of 1599, the rule, the law, and this is just that publication. There's the chapter 1, subsection 10. So it's all there, whether we like it or not. And this is going back to the same question we discussed before, as you need to document what are we doing that can only be done in the hospital, and what exactly are we doing that can only be done in the hospital. ICD-10 has acute kidney failure, chronic kidney disease, and then the unspecified kidney failure, and in the N series. And then we've broken it down into the more specificity. So your coders may be asking you, well, doc, you put in acute kidney failure, acute kidney injury. What is it due to? Is it tubular necrosis? Is it cortical necrosis? Is it medullary necrosis? And you're going to say, hey, I don't know. And what they'll choose is just the unspecified one. So again, that's a lesser payment for that. But if you do know it, write it. Same thing with chronic kidney disease. Which stage? A lot of times they'll ask you, hey doc, what stage of chronic kidney disease do you think this patient is in? So simply writing CKD is not enough, because anything that's not complete is going to be put into an unspecified code. ICD-10 has now actually clubbed diabetic chronic kidney disease and hypertensive chronic kidney disease. And what that means for us is, when we are writing, we need to put in is, do we think it's from hypertension or diabetic, or is it from both? So we are back to our case, and you guys had already answered this. We have an abnormal creatinine of 2.6. So let's look at this particular case, and the box is in red. So the baseline for this patient from a history was 2.3. She came in with a 2.5, got IV fluids. Day 1 of hospitalization is 2.5, day 2 is 2.3, day 3 is 2.3. Calcium levels are low, but I want you to focus on PTH level of 99. And this comes back to plain simple medicine. You know that if the calcium level is low, the PTH is high, our patient falls into this red box, which is secondary hyperparathyroidism, which is usually due to chronic kidney disease. And so this 2.5 was just a chronic kidney disease. She's always had it. She shouldn't have even been in the hospital. She did, however, have nitrites positive and leukocytes positive. Again, that was a UTI. Do we have to have UTI with IV Rocephin? No, you can treat with oral antibiotics. Hyaline casts were few, and just for just a refresher course, hyaline casts are normal. They are just TAM horsefall proteins that are now hyaline casts. If you, however, have granular casts, that's an acute tubular necrosis. RBC cast are acute glomerulonephritis. WBC cast is pyelonephritis. Waxy cast is chronic kidney disease, and fatty cast is nephrotic syndrome. And this, you'll be surprised, we refer to this cast discussion in almost every appeal for kidney disease, because now we can acute kidney disease due to we have granular cast, so we know it's acute tubular necrosis. In this particular case, she didn't have either of those. She was someone simply who had chronic kidney disease with an elevated PTH that was found before she was going for right foot surgery. She was given some IV fluids, and we look at all these. The output was great, so that means she wasn't anuric. If someone had a creatinine of 2.5 with a sudden increase and there was no change in urine output, that always doubts the diagnosis. But this lady was having great urine output, if you look here. So in this particular case, this case was eventually denied, and their reason was no medical necessity of inpatient level of service, no medical necessity justification for continuation of stay in hospital, and the medical director actually cited a CMS guideline saying disagree with inpatient admission per Social Security Act 1862, and that's the reference to that 2,000-page document, A1A, which talks about determining medical necessity appropriateness of admission. So from our standpoint, there was nothing we could do to argue this case. That whole 4-day of hospitalization was technically a write-off for the hospital. But in our second case, Let's see. So this patient unfortunately was symptomatic. There's intractable nausea and vomiting. Look at the blood pressure, 95/52, 95/54, 99/60. After 2 days, I think this is a 24-hour window, pressure started to come up. So this patient was pre-renal, was symptomatic, that was put in the record. I end up using a lot of these nursing records to formulate the appeal. And look at the beautiful recovery, 3.1 to 1.9 to 1.6. Hemoglobin was 9.5, 9.5, 9.1. Platelet counts were good. And in this particular case, we looked at the intakes. This patient was getting a good amount of fluids till day 3, which meaning we were still treating this patient for fluids. There was good bowel movements, there was good urine output. So we started off with a 1x urine output, and by the time we were discharging, there was 5 to 6 episodes of urine. So this patient had oliguria that was treated with this, and this patient was put in as inpatient. Payment was made, there was no issue there. So just refreshing: acute kidney injury, acute kidney insufficiency, and then remember what we need for documentation. Now, everything that I said, we've found evidence that CMS supports it. So there is National Coverage Determination guidelines for ultrafiltration, hemoperfusion, hemofiltration. I mean, this is all out there. The fact that this is not part of our training or education doesn't discount the fact that payers and CMS and insurance companies, they can use these guidelines. All that we have put in is from evidence-based medicine, and this is how we will present all our topics. When you go on to the learning management system, if you click on these will open up to the guidelines. Feel free to go through them. I think even if you know what is in them is good enough. We don't need to read the entire page. But this is what we had for you. What we do have is we have Dr. Sharma, who is a very senior hospitalist at the Mayo System. Are you on right now, Dr. Sharma? So what are your thoughts? And Dr. Sharma has a background with ACP, Society of Hospital Medicine. He's done a lot of initiatives with the Mayo System. What's your take on this?
Struggled was moving from a profession of medicine to the business of treating people with medical problems. So we have a lot of people here accountable for, a lot of stakeholders, like our regulators, our advisors, our payers, hospital patient advocacy groups, and everybody has become very savvy consumers of healthcare information. So long story short, whatever we write, whatever we document, actually translates into our case mix index, our observed versus expected mortality ratio, and people use these numbers to compare hospital A to hospital B, organization A to organization B, and big groups like Leapfrog, the Hospital Compare, and everybody else like HCAPS, they use this data. So this is publicly reported. And a lot of people are using this to negotiate how much they're going to pay us. So besides the money equation, it kind of helps us sustain long term. So people know right off the bat when somebody comes to the hospital is how sick you are with your CCs or major CCs. If you document them properly right on day one and throughout the stay and on day of discharge. So people can focus on really what's the complexity of your particular program or your patients in that population mix. So I think there's tremendous work, and we did a lot of work with our physicians, with our physician advisors and our hospitals group. And over the last couple of years, we kind of are trying to cut back on RAC audits, compliant with observed versus expected mortality, at the same time OBS and inpatient statuses. And we're seeing a lot of monetary value. We saved about close to $2 million in the last couple of years just by avoiding a lot of these pitfalls. But there's a lot of work that needs to be done. I think the biggest thing is to convey to the frontline staff that this is really, really important work. It's not going away. And the more we all understand and share risks, it's probably better for all of us. And I think that's kind of one of the teaching point to be said to people is that, things are changing. We all need to adapt. We may not agree with a lot of stuff, but this is the way of doing business in the future.
Good. Thank you so much. Dr. Chada, you had raised your flag. Did you have a question?
We have done a couple of appeals against acute renal failure where they have denied saying that the creatinine increase was just from a pre-renal cause, and Acute corrected it pretty promptly. So I think they bring down the diagnosis to acute renal insufficiency rather than failure. We just need to be aware of the difference between the two. Yeah,
Okay.
that's my take on the. Yeah.
Good. Good. Patricia, any thoughts from your end? Okay. And my doc colleagues, any changes you want in future presentations? Okay. Well, that's the end. If there's questions, we would be happy to answer.